Next up is Fengyi Zhang, who's one of our neurosurgery attendings here and who has been with us for a couple of years now. Came up from Texas and actually trained with us prior to that, and he's going to give his perspectives on current evidence-based review on spinal cord injury.
Thank you, Bellabarba. So my talk will be focused on the acute spinal cord injury. How do we manage at this time? The incidence of the spinal fracture is about 64 over 100,000 population, and the spinal cord injury occurs in about 4 in 100,000 population. This is from the old national spinal cord injury data back in 1970s. We don't know if there's any change over the time, and also it's estimated that the neurological deficit occurs in about 10 to 25% of all spinal column fracture patients. The treatment of the spinal cord injury starts at the scene of the injury, but today we're going to focus on the in-hospital management of this spinal cord injury, including the support, the spinal cord perfusion pressure, and also the steroid use, and the urgent initial close reduction, and the last, the surgical intervention, providing the fixation and the stabilization. First, we're going to talk about the support of the spinal cord perfusion pressure. The spinal cord blood flow comes through 1 anterior and 2 posterior spinal artery. For the entire spinal cord, the mid column of the thoracic area is the watershed area. And at each given level, as Dr. Tater indicated, the central area is a watershed area. The perfusion of the spinal cord is maintained by the autoregulatory mechanism over a wide range of the systemic blood pressure. Now, in the laboratory research, it was found that the autoregulation of the spinal cord blood flow is lost in the spinal cord injury model. The post-traumatic spinal cord ischemia become progressively worse over the first several hours after injury, and also the post-traumatic hypotension will lead to the reduction of the spinal cord blood flow and the perfusion, and also can worsen the neurological outcomes. And the 9 articles look at the pharmacological agents for the hemodynamic support. The calcium blocker and the vasopressor, and also the colloid or the whole blood was given to elevate the mean arterial blood pressure, which lead to the increased spinal cord blood flow. With one exception, the Guha's group find back in the 1980s that by extremely increase the systemic pressure by epinephrine, which did not significantly increase the spinal cord blood flow. In clinical study, there's a class 3 evidence suggests that the optimizing the spinal cord perfusion may improve the clinical outcomes. There's no class 1 or class 2 evidence exists. I mean, due to the consideration of the hypotension is the basic principle of the ethical medical practice in the treatment of the trauma patients. So the class 1 evidence will never be able to obtain. This is the article published by Phelins and Vaccaro looked into the several parameters of the management of the blood pressure of the spinal cord injury. One is that what's the target map we should set, and the second is for how long the treatment should last in the hospital, and also with what the agent we should use. Several authors of the article initiated the treatment when the blood pressure the maps dropped below the 85 and the 90. Compared with all these studies, there's no significant difference found in terms of neurological recovery. And the most authors arbitrarily treat for 5 to 7 days. However, most of these reported findings were not specific for their effect on the neurological recovery as well. The variety of the vasopressor has been used, but which one is better? Due to the heterogeneity of these studies, there's no statistical analysis can be performed. The AANS and the CNS joint session guideline published in 2001 recommended that to keep the systolic pressure more than 90, and the MAP keep it around the 85 to 90 for about 7 days, and use the volume expansion or vasopressor as needed. But working in the level 1 trauma hospital like Harborview, we all know the side effect and the outcome of prolonged drip with the vasopressor. So one of the future investigation we can focus on managing the intrathecal pressures. As in the neurosurgery field, we all know that by treating the traumatic brain injury, there is a high elevated intracranial pressure. By control the high intracranial pressure, which can lead to increased cerebral perfusion and lead to the better outcome. There's one clinical study published from Vancouver, Canada, shows that there is increased intrathecal pressure in the post-op patient in the spinal cord injury, and which can lead to decreased spinal cord perfusion pressure. So whether by reduce this intrathecal pressure instead of just driving up the systolic pressure can lead to improved spinal cord perfusion and to the better outcome is need to be studied. The immediate after the publish of this NASAS-3 study, there's a controversies. The NASAS-3 questioned about the statistical analysis and the randomization, and also the clinical the endpoint in use in this study. Failings, concerns about the side effects and the post hoc nature of the data analysis and the effect size. In addition, there's 8 clinical trials which failed to duplicate the NASAS results, found there's no improvement in the neurological outcome. Instead, it was found that the steroid use have a higher incidence of the pulmonary and the GI complications, and also is associated with the acute care charges and the longer hospital stay. Therefore, based on the controversies, each specialty in the spine surgery, neurosurgery, and emergency medicine conduct their own evidence-based reviews, and the conclusions are pretty uniform, which is the mesoprad should be regarded as a treatment option, but not a standard of care. And this is consistent with the joint session guideline published in the 2001 as well, which recommended the steroid as an option in the treatment of acute spinal cord injury that should be undertaken only with the knowledge that the evidence suggesting the harmful effect is more consistent than any suggestion of a clinical benefit. The next topic we will talk about the cost reduction. Over the past several decades, there's a class 3 data, numerous publications suggested that the cost reduction provides the best chance for the neurological recovery by expeditiously relief of the extrinsic spinal cord compression. The goal of the reduction is to restore the anatomical alignment of the spine as soon as possible. We normally can achieve this at Harborview by like 2 or 3 hours after the patient arrives. And also the success rate, the published data shows is about 80%. In our Harborview series, we show this about close to 97%. And in all of these reduction cases, we found that there's a significant improved neurological exam, either in the complete spinal cord injury and also in the incomplete spinal cord injury. Obviously, it has the risks. The transient neurological deterioration is about like 2 to 4%, while the permanent neurological deficit is about 1%. This is according to the published data. The controversy about the close reduction, one of the topics is that whether we should get the pre-reduction MRI scan. The potential danger of the close reduction in the sedated patient has been reported, and also the proponent for the MRI scan is mainly concerned about whether there's a disc herniation causing the further neurological deficit. Indeed, there's isolated case report that shows that the neurological deterioration after reduction is associated with the disc. However, over the past decades also, there's very few, I only encountered like 2 or 3, the report shows that the neurological the deterioration is truly because of disc herniation. It's well established that in the awake and the alert patient, the reduction is pretty safe without MRI scan. Vaccaro's group looked at the MRI scan in 11 consecutive patients before and after the reduction. Actually, the disc herniation is increased from 18% to the 56% through the reduction process. However, there's no case of neurological deterioration was found. In our published data here, in the 76 of the 82 patients who went through the reduction, we had the post-reduction MRI scan shows that this disc herniation occurs in about 22%. We only had one patient in these 82 patients that had the neurological deterioration. This one was proven because of this burst fracture. There's no disc compression on the MRI scan. Therefore, the joint section guideline recommended that we use the early close reduction of the cervical spine, the injury with the cranio-cervical traction, and they recommended the pre-reduction MRI scan in the unexaminable patient. In our Harborview practice, and based on the benefits in the vast majority of the cases, far outweigh the any reversible deficit that may occur, we normally proceed with immediate reduction without waiting for the MRI scan, and also close the monitoring of the neurological function. Obviously, is strongly emphasized. The author of these articles made the recommendation, which is endorsed by a panel of the 10 experts in the field of spinal cord injury in a modified Delphi process. Surgical decompression of the injured spinal cord is need to be performed within 24 hours when medically feasible. And the timing of the surgical decompression, or whether this surgery is indicated at all in the patient with central cord injury, remains unclear. There are clinical and the neurological and the functional benefits of the early decompression of the spinal cord. Thank you.
Dr. Katter, give us round two on where do we go from here with spinal cord injury research.
I'm just going to end up with a brief overview of this clinical sciences research that I have been involved in, and these are the topics that we're going to briefly cover. This is really old, and probably you are well aware of the advantages of acute spinal cord injury units, but of historical interest, and that was my job, Jens and Randy, to give a perspective. When I started, there was no such thing as an acute unit. We had chronic units, we had rehab units, but there was no place that you could actually send a patient to where there was a specialized team and equipment, personnel, multidisciplinary, etc. So this was something that we looked into, and obviously the critical care management of spinal cord injury, of being able to treat the whole patient right from the very first minute, is what makes gains. And over the years we've identified the group of patients that in fact should be intensively monitored, not only in an acute unit, but in an acute unit that has full capability for intensive care monitoring. So we looked at this, at the results of doing this, and it was of interest, and I think you'll be interested, that with the establishment of an organized system of triage to an acute unit, with a goal, for example, of less than 2 hours from trauma to admission, that you really can make gains. And in fact, you do get, just the mere establishment of an acute unit does bring about earlier admissions of patients, and we proved that there is more neurological recovery, lower mortality rate. That before the establishment of organized units, the mortality rate was twice what it currently is. And we were able to lower the complication rate, reduce the length of stay. One of my first attempts to look at this in patients was published many years ago, and it is of interest that it still is one of the few prospective studies of acute care and whether surgery helps. And in fact, we did not show that surgery helped. We could not prove that patients recovered better as a result of surgery. And in fact, some of the complications in those operated on, with thromboembolic being the one that was increased with early surgery. The other study in the literature is Alex Vaccaro's study, but this is really complicated by the fact that early, in his view, was less than 72 hours, which we now know just doesn't wash. So Michael Failings has been very vigorous, and with Alex Vaccaro, they have continued on the Staskus group, which we put together a long time ago, and in fact tried to get NIH funding for this study of, does surgery help, and if so, when should it be performed, but we didn't achieve that. And we, so that was in 1995, and he and Alex have turned this into a multi-center trial, but without randomization. So it doesn't have the full weight of a randomized trial, but after struggling with this for many years, I don't think it will ever get done. I don't think there will ever be a randomized trial of early surgery because of the data that has appeared both from the basic science laboratory that I shared with you earlier today and from the data that Fonji has given you, and also from this current results of the Staskus trial, which now has 267 patients prospectively entered and a more appropriate early time of less than 24 hours. This is feasible in virtually all centers. In fact, we showed many years ago that even less than 12 hours is feasible, but this was what the Staskus group has now shown, and there is better recovery and fewer complications. The lovely thing is not only is there better neurological recovery, but this recent iteration of Staskus has now shown that there are fewer complications. So that's lovely. So this is where we're at currently. Another topic that has been of major interest to me is to determine why neurological recovery occurs. And there are really many reasons for it. Very important features that if you look at the natural history of this, most patients do show some neurological recovery. Now, in many cases, it's just root recovery at the level of the injury or just slightly caudal to the injury, a C5 dropping to a C6 because of root recovery. But in a few cases, it actually is cord recovery. And how does this cord recovery occur? Well, a number of possibilities. The resolution of acute injury events, for example, hemorrhages, can absorb the resolution of secondary mechanisms such as swelling can get better, and this issue of regeneration. Is there, in fact, natural regeneration? And I believe there is, following the experiments of Aguayo and others 25 years ago. So, yes, neurological recovery can occur. If you look at some of the older studies, and this is now many years old, they showed the same thing. And it's shown with this comparing the admission grade with the discharge grade. And you can see, for example, if you're a C on admission, and the Frankel is the old Asia, that if you're a C, about half the patients in the C category do recover to a better level. So, in fact, this is the natural course. Many patients do recover. And We looked at this in a group of more than 500 patients to try to find out what are those recovery factors that we should be concentrating on in our patients. And to no one's surprise, the ASIA grade on admission is #1 factor. So as the better you are going into an acute unit, the better you are coming out after a spinal cord injury. Obviously, A is the worst, D is the best. It was of interest to see that the cervical cases recovered better than the others. And that's probably, again, this issue of root recovery where we can be much more certain of recovery. And a very important issue is the trauma burden. And that came out very clearly. And we measured it at that time in terms of ISS, or injury severity score, that the multiple trauma patients are definitely at a major advantage. And those are the ones that we really have to work on to make sure that hemodynamic factors, respiratory factors are well looked after, that the whole patient is treated from the very first. Otherwise, neurological recovery is going to be compromised. And I think that's something that we have all learned over time. And that the recovery over time, for example, when in our own center, if we look at those who recovered before the opening of an acute unit and afterwards, the recovery is better afterwards. In fact, if you look at the demographics of spinal cord injury over the last 30 or 40 years, we used to be admitting about 60% complete cases, that is ASIA A, to our units, whereas now it's the opposite. We're now admitting about 60% incomplete. And that means, in my view, the combination of seat belts, of airbags, of better triage, of no mismanagement of patients early on by well-wishing bystanders. So all of these factors have resulted in this change in the demographics that are lovely to see. And then what doesn't affect neurological recovery? Now that I'm getting older, it's very nice that age doesn't affect neurological recovery. So the old folks really do have as good a chance to recover neurologically as the young ones, unless somebody disproves that. So you got to work just as hard for the old ones as you do for the young ones. Gender makes no difference. And this is a bit odd in our data. The time from trauma to admission didn't make a difference, and neither did the cause of injury, whether it was a diving episode or a fall downstairs. That didn't seem to matter. And the last thing that I'm going to mention is the issue of prevention, because we all need to practice prevention. We need to preach prevention to our communities. And this is an example of prevention working. Strictly related to the issue of hockey injuries. There's a fair amount of hockey in Seattle. And we have collected data on spinal injuries in hockey for, over a long period of time. And we have 300 plus cases. You see mostly males, some deaths, mainly pulmonary emboli. And a lot of these are severe enough to put these kids in wheelchairs for life. How did these occur? So we carefully analyzed in those cases what are the factors contributing to this problem of spinal injuries in hockey. And it was, I should say, of increasing importance. And you see that most of these were injured in games. Very often it was a player striking the boards. That's not such a surprise. Or multiple injuries. What we didn't know until we looked at the data carefully is that many of these kids were being injured by being checked or pushed from behind. So just that one item on the list of causative factors raised flags, and steps were taken to counteract that. So even though the issue is multifactorial, the speed and weight of the players are way up. I used to be the average size hockey player, if you can believe it. So kids weigh more and skate faster. The game is much more aggressive, and risk-taking is up. Lack of respect, terrible problem. Nobody knew about these injuries, who got them. There wasn't good information available. Nobody was practicing neck muscle strengthening among these kids, and obviously impact with the boards, but most importantly, checking and pushing from behind, and difficulties with coaching, refereeing, and league factors that held back the information about what was going on, similar to the situation in pro football today, which is finally being looked at with respect to concussions. So a major campaign was instituted not only in Canada but in the USA as well, to try to reduce these injuries, and a number of strategies were developed, listed here. Most importantly, rules changes. Whereas there was no specific rule against checking or pushing someone into the boards from behind, there was a rule instituted once this information became available, not really enforced until the late 90s when the campaign got going. But here's the result of all of that effort. So you see that in this era, they were running the number of injuries in each of these 3-year periods has dropped dramatically to more recent levels, and also the number of severe injuries has dropped as well. So primary prevention, that is trying to stop the injury from happening in the first place, is should be a part of the work of all spinal surgeons, as well as the secondary injury prevention measures such as neuroprotection and trying to regenerate the cord. So that is my personal story. Thank you.